Hello guys, welcome to my channel, and in this lecture I'm going to talk about cholinergic antagonist drugs. Okay, so in cholinergic antagonists we can divide cholinergic antagonists into muscarinic antagonists and nicotinic antagonists. Okay, in this lecture we will focus on the muscarinic antagonist drugs. Okay, so what are the muscarinic antagonist drugs? So let's see, or let's assume that this is a nerve terminal or something, and acetylcholine is released from this nerve terminal. And there is this muscarinic receptor. It can be M1 or M2 or M3, 4, or it can be 5, M5. Okay, so acetylcholine will act on this receptor and will activate this receptor. Okay, if we can block this receptor anyhow by any drug, like we say that there is a drug called atropine that blocks this receptor. Okay, so if this receptor is blocked by this atropine, then acetylcholine can't act on this receptor, and it will, or it can't produce its biological effects. So muscarinic antagonist drugs are the drugs that antagonizes the muscarinic receptors so that acetylcholine can't produce its biological effect, or the opposite effect of acetylcholine will be produced. Okay, so muscarinic antagonist drugs can be called that anti-muscarinic drugs. Okay, it also called, or we also call it anti-muscarinic drug. So let's classify these muscarinic or anti-muscarinic drugs. If we classify these drugs, they can be classified into natural and synthetic drugs. Okay, so what are the natural drugs that comes from the nature? Okay, so comes from the plants or animals. Okay, so we have atropine here, we have scopolamine, and we have homotropin. So this atropine is the prototype of the muscarinic antagonist drugs or anti-muscarinic drugs. This is the prototype of the anti-muscarinic drugs. Okay, so where the name atropine comes from? So atropine comes from the name called Atropa belladonna. Okay, this is a plant, and the extract of this plant is atropine. Okay, so belladonna, what do you mean by the belladonna? Belladonna means beautiful lady. So in 14th or 17th century, 14th, 15th, 16th and 17th century, 14th to 17th century, I can say that. So in this era, the ladies use the extract of this Atropa belladonna plant. Okay, so use this extract to make their pupil bigger. Okay, so that they can attract man. Okay, so that's why this plant got named from this beautiful lady, or it got the name called Atropa belladonna, and from there this drug is called atropine. Okay, what are the synthetic drugs? Okay, synthetic drugs can be again divided into two types. There is tertiary amine and there is quaternary amine. Okay, So in tertiary amines, we have many drugs. I can say 2-3 names like tropicamide. We have benztropine. We have scopolamine. And in quaternary amines, we have tiotropium. We have glycopyrrolate. Okay. So these are the drugs we have in tertiary amines and quaternary amines. So why we divide it into tertiary amines and quaternary amines? If we see that tertiary amines are the non-polar drugs, or they can easily cross blood-brain barrier, so that they have their CNS effect. But these quaternary amines can't cross the blood-brain barrier. Okay, can't cross blood-brain barrier because they are polar drugs. So polar drugs can't cross the blood-brain barrier, and that's why they don't have the CNS effects. Okay. So let's see the effects of antimuscarinic drugs in our body. So if we see the effects of the antimuscarinic drugs in our body, first of all, we will come from the top to bottom. So first of all, we will see the central nervous system, what it causes or what happens in the central nervous system if we give atropine to a patient. If we give atropine to a patient, it causes minimal stimulatory effect. So it has stimulatory effect, or it causes stimulation of the central nervous system, but it has minimal stimulatory effect. Okay. On the other hand, if we see scopolamine, okay, it has effects on H3 receptor or histamine receptor. Okay, so it acts as a blocker of the H3 receptor. It blocks H3 receptor. When it blocks H3 receptor, it causes drowsiness and amnesia. Okay, so it causes CNS depression mainly, but atropine causes minimal stimulatory effect. If we give atropine in the toxic dose, okay, atropine or scopolamine in the toxic dose, they can even cause hallucination. Okay, and that's why it causes hallucination. That's why scopolamine is also called the devil's breath. Okay, because in toxic dose it causes hallucination. So if a person gives scopolamine to a person, okay, if I give scopolamine to a person, he will be hallucinated. He can be hallucinated for a few hours, few minutes to few hours, so that it is also called the devil's breath. Okay, the kidnappers or you can say the thieves use this scopolamine to hallucinate a person and steal their money and something like that. Okay, so this is also called the devil's breath. Okay, then in central nervous system, I want to talk about the disease called Parkinson disease. Okay, so what happens in Parkinson disease? What is the pathology of Parkinson disease? We have to first understand the Parkinson disease. So let's see, in basal ganglia, we have corpus striatum, and we also have here substantia nigra. Okay, and we have thalamus here. Okay, and we have cortex here. Okay. So from substantia nigra, there's some dopaminergic fibers that go to the corpus striatum, and they got synapse with some GABAergic fibers, and these GABAergic fibers come back to the substantia nigra, and there are some nerve fibers that goes from the substantia nigra to the thalamus. Okay, and GABAergic fibers control these fibers, and there are some nerve fibers that goes from the thalamus to the cortex. Okay, and from the cortex there are some nerve fibers that goes to the voluntary muscles. Okay, so if I draw a muscle, you can say that okay, so voluntary muscle. Okay, so and I want to add there are some cholinergic fibers that enter into the corpus stratum. So when the dopaminergic fibers okay, so dopamine release from the dopaminergic fibers into the synapse, they stimulate the GABAergic fibers. Okay, so GABA is a inhibitory neurotransmitter. Okay, and that inhibit this neuron that goes from the substantia nigra to the thalamus. So this inhibit the thalamus, and this will inhibit the nerve fibers that go from the thalamus to the cortex, and this will eventually inhibit the nerve fibers that goes from the cortex to the skeletal muscle. Okay, and that's why there will be no excessive stimulation of the skeletal muscles. Okay, so this is the physiological system, how our body maintain the balance between the stimulation of skeletal muscles. Okay, but if there is Parkinson disease, if any person is suffering from Parkinson disease, there will be degeneration of these dopaminergic fibers. So there will be less dopamine, but there is cholinergic stimulation coming. Okay, so what these cholinergic fibers then do is they inhibit these GABAergic fibers. When they inhibit these GABAergic fibers, there will be less GABA in the synapse. So if there is less GABA in the synapse, there will be excessive stimulation of the thalamus, or there will be stimulatory signals goes from the substantia nigra to the thalamus, and there will be excessive stimulation of the cortex by thalamus. By the nerve fibers goes from the thalamus to the cortex, and there will be excessive stimulation from the cortex to the skeletal muscle, and there will be muscle spasm, and there will be bradykinesia. So this is the physiology or pathophysiology of the Parkinson disease. So in this Parkinson disease, we can do that there is this acetylcholine releasing from this cholinergic fibers. So we can reverse the action or block the action of the acetylcholine. So how will we block the action of the acetylcholine? By anticholinergic or antimuscarinic drugs. So in this case, we use the drugs called benzhexol, benztropine, and procyclidine. So these drugs block the acetylcholine and decrease the inhibition of the GABAergic fibers. Okay, so there will be relief of the Parkinson disease, or there will be relief of the bradykinesia. Okay, so that's why we use the antimuscarinic drugs in the Parkinson disease. Here I'm going to talk about another disease called motion sickness. Okay. So what happens in motion sickness that there is our vestibular system. Okay, so there is our vestibular system, and in our vestibular system, okay, so there is our vestibular system, and in our vestibular system we have rich in M1 and H1 receptors. Okay, so we have M1 and H1 receptors, and if there is any imbalance in the vestibular system, this M1 and H1 receptor gets stimulated, and they give signal to our brain or to our central nervous system, and they give signal to the nucleus tractus solitarius and chemoreceptor trigger zone, and this stimulates the vomiting center present. This vomiting center is stimulated. Okay, so where the vomiting center is present? Vomiting center is present at the area postrema of the medulla oblongata. So this vomiting center is stimulated. When this vomiting center is stimulated, it causes a stimulation of the diaphragm. It causes stimulation of the diaphragm, contraction of the abdominal muscles, okay, and also it causes stimulation of the esophagus, and it causes relaxation of the lower esophageal sphincter, and that causes vomiting. Okay, so in this disease we can simply block this M1 receptor or H1 receptor to prevent this motion sickness. So here we will not talk about the H1 receptor, we will talk about the M1 receptor. How can we block the M1 receptor? We can block this M1 receptor by the drug called scopolamine or hyoscine, and this scopolamine blocks the M1 receptor and prevents this motion sickness. Okay, so and we mainly nowadays we use this scopolamine as a transdermal patch. It is really give a good work and long half-life by this transdermal patch. Okay, then let's see eyes. Okay, assume that this is an eye. Okay, let's see that there is the pupil. Okay, let's make it less. Okay, so in this around the pupil we have circular muscles and we have radial muscles. Okay, so in this circular muscle we have M3 receptor. So M3 receptor can be blocked by the antimuscarinic drugs, right? So when M3 receptor is blocked by the antimuscarinic drugs, the sympathetic system gets the upper hand. So when the sympathetic system gets the upper hand, it contracts these radial muscles. Okay, so when the radial muscles gets contracted, so what happens? So when the radial muscle gets contracted, the circular muscles are same, but the radial muscles get contracted, so the pupil will be enlarged. Okay, or there will be mydriasis. We can say that it causes mydriasis. So antimuscarinic drugs causes mydriasis. Also, there is some effects in the ciliary muscle also. So when I see that there is a eye and there is the ciliary muscles, okay, we have also M3 receptor in the ciliary muscle, right? So when M3 receptors are blocked, then sympathetic system gets the upper hand and it causes paralysis or relaxation of the M3 ciliary muscle, relaxation of the ciliary muscle, and we call it that the ciliary muscle got paralyzed. Okay, and the ciliary muscles got paralyzed. So when ciliary muscle got paralyzed, we name it as cycloplegia, and in this condition the person lost the accommodation reflex, or they can't accommodate like for near vision. Okay, so they can't accommodate for the near vision, so that the ciliary muscle gets paralyzed, and by this thing it can block the canal of Schlemm there. So when the ciliary muscle gets relaxed and they get paralyzed, they can block the canal of Schlemm. If the okay, so it can block the canal of Schlemm, or it can be said that if the canal of anterior angle of any person, if the anterior angle is small, then it can be easily blocked by these drugs, antimuscarinic drugs, and it causes increase in intraocular pressure, and it can cause acute glaucoma. So if I block the canal of Schlemm, the aqueous humor cannot be drained through the canal of Schlemm, and it will cause the increase of intraocular pressure, and it will cause acute glaucoma. Okay, and also they decrease the lacrimation in the eye. Okay, so antimuscarinic drugs decreases the lacrimation, and it causes dry eyes. Okay. So we can use these drugs as mydriatics. So ophthalmologists, for the examination of the retina, they use these drugs as mydriatics. The drugs like cyclopentolate, tropicamide, these drugs are commonly used as mydriatics because they have the short half-life. Tropicamide has the half-life called 15 to 60 minutes, and cyclopentolate has the half-life of 3 to 6 hours. Okay, in case of if we need a long duration of action, we can use atropine or scopolamine, and also you can use homatropine. Okay, but as only for mydriasis, we don't really use these drugs. If we need mydriasis and also cycloplegia, we can use these drugs. But for mydriasis, only mydriasis, we can use these drugs. We should not use these drugs because this has severe side effects like acute glaucoma and dry eyes. So for only mydriasis, we can use the drug called phenylephrine. And this drug is an alpha stimulatory drug or alpha agonist drug, and it also causes mydriasis. So we can use phenylephrine for only mydriasis. If we need cycloplegia with them to lose the accommodation reflex of the patient, we will need these antimuscarinic drugs like atropine, homatropine, cyclopentolate, and tropicamide. Okay. Let's see what happens to the cardiovascular system. Okay, in cardiovascular system, we have the M2 receptor in the heart. Okay, so if this is a heart, this is a heart. Okay, so this is a very, so if this is a heart, say we have the M2 receptor on the heart. Okay, so we have the M2 receptor on the heart. Okay, so in moderate to high dose of atropine, if we give moderate to high dose of atropine, this moderate to high dose of atropine blocks this M2 receptor. So when the M2 receptor is blocked, okay, so the sympathetic system will get the upper hand, and they will cause increased heart rate, okay, and increased force of contraction. So they mainly cause the tachycardia, right? But in lower dose, if we give lower dose of atropine, they causes initial transient bradycardia. How they causes initial transient bradycardia? Okay. In lower dose, it causes inhibition of the M1 receptor or block M1 receptor first. First, they block the M1 receptor. Before blocking the M2 receptor, it blocks the M1 receptor. Okay. So, M1 receptor is located in every presynaptic nerve terminal. Okay. So, there is the M1 receptor. And if you say that this is a myocyte, cardiac myocyte, there is this M2 receptor. Okay. So, when the acetylcholine release from this nerve terminal, okay, they causes stimulation of the M1 receptor, and it gives a negative feedback to the nerve, and it will decrease the release of the acetylcholine. Okay. If the atropine blocks this M1 receptor, acetylcholine can't stimulate the M1 receptor in the presynaptic nerve terminal, and it will not give any negative feedback mechanism. So, if it doesn't give any negative feedback, then there will be increase in acetylcholine release from the nerve terminal, and that will lead to bradycardia, because this acetylcholine will act on this M2 receptor, and it will cause the bradycardia, and it will be initial and transient. Okay, but after that it will cause tachycardia again because of the blocking of the M2 receptor. Okay. Now, in the cardiovascular system, there is heart and also the vessels. Okay, so blood vessels. So in blood vessels, at toxic dose. Okay, so at toxic dose, this acetylcholine, the atropine, will cause cutaneous vasodilation. And also, in some individuals, in normal doses, it can also cause cutaneous vasodilation, especially in the upper part of the body. The mechanism is not known still. So that it will cause cutaneous vasodilation at toxic dose, and in some individuals at normal dose, it can cause cutaneous vasodilation, mainly in the upper part of the body. Okay. So, what is the use of these drugs in this cardiovascular aspect? Okay. So, sometimes we see that these MI patients or myocardial infarction patients or MI pain, if there is MI pain, it comes with marked bradycardia. Because of the marked reflex vagal inhibition. Because there is severe pain. Okay, so vagal system causes inhibition of the heart. Okay, and that will lead to bradycardia. Okay, so there will be vagal stimulation, and vagus nerve will cause the heart to decrease its heart rate, and it causes bradycardia. So, and it can lead to decrease in cardiac output, and it can lead to heart failure. Okay, so by using atropine in this condition, we can reverse this bradycardia and causes the heart to pump efficiently. Okay. Also, we use atropine in hyperactive carotid sinus. Okay, so we use atropine in hyperactive carotid sinus. This is the same mechanism that hyperactive carotid sinus causes vagal inhibition. Okay, so there will be bradycardia. So we use this atropine to causes reverse this bradycardia. There are some autoantibodies that stimulates the M2 receptor and causes bradycardia. So in which diseases we find these autoantibodies? We can find these autoantibodies in Chagas disease. Okay, in Chagas disease, we find this in idiopathic cardiomyopathy, and also in the Graves disease. Okay, so in these conditions, there will be autoantibodies that stimulates the M2 receptor and will cause bradycardia. And for blocking this M2 receptor, we use atropine. Okay. Then come to the respiratory system. If we come to the respiratory system, we have this bronchial smooth muscles. Okay. So bronchial smooth muscles. In bronchial smooth muscles, we have the M3 receptor, right? So let's make it. This is the M3 receptor. And it causes, mainly what it causes? It causes bronchoconstriction. So by blocking these M3 receptors, we can cause bronchodilation. And it can also, by blocking these receptors, we can also decrease the bronchial secretion. So why we can use these drugs? So we can assume that it can be used in asthma and chronic obstructive pulmonary disease. Okay, so in these cases, we will use the selective M3 agonist drugs. M3 antagonist drugs. Okay, selective M3 antagonist drugs like ipratropium, we can use tiotropium, aclidinium, umeclidinium. Okay. In gastrointestinal tract or in GIT, what it causes? It causes decrease in motility. So it can cause constipation, right? Also, it causes decrease in secretion, and especially they decrease the gastric ACL secretion, because acetylcholine causes increase in histamine secretion, and from the enterochromaffin-like cells, they causes increase in histamine secretion, and this histamine secretion act on the parietal cell and causes increase in ACL secretion. So this causes decrease in ACL secretion. So we can use these drugs. We can use the drugs called pyranzapine, the antimuscarinic drugs, and also talanzapine in peptic ulcer disease to decrease the secretion of ACL. Okay. Then we have the genitourinary tract, obviously. So what happens in genitourinary tract? So let's see. So in the bladder, we have the detrusor muscle and we also have the sphincter, right? Okay. In the bladder, we have the sphincter and we have the detrusor muscle. Okay. In this detrusor muscle, we have the M3 receptor. By blocking this M3 receptor, we can relax the detrusor muscle. Okay. And if we block the M3 receptor, the sphincter will be constricted because sympathetic stimulation will get the upper hand, the sphincter will be constricted, so there will be slow voiding of urine. Okay, so there will be so slow voiding of urine. So we can use these drugs. We use the drug called oxybutynine, okay, to relieve the bladder spasm. Bladder spasm. So we relieve the blood to relieve the bladder spasm. We use these drugs called oxybutynine that act on the M3 receptor and block these M3 receptors. Okay. And relief where the relief of the where the bladder spasm occurs, in urological surgery, mainly there will be bladder spasm. So we can use the oxybutynine to relieve the bladder spasm and causes the slow voiding or urinary inconsistency will be reduced. Okay. And also these drugs antimuscarinic drugs, if we use this long term, the long-term use of these drugs can cause impotency. So it causes impotency because acetylcholine is the responsible for the relaxation of the smooth muscle in genital erectile tissue. So what happens here is, for erection, we need the relaxation of the smooth muscle. Okay, so acetylcholine is responsible for the relaxation of the smooth muscle in the genitalia. Okay, so if there is no relaxation, there will be no erection, and so that because these antimuscarinic drugs block the acetylcholine, so that they causes impotency. Okay, then we have sweat glands. Okay, and it causes suppression, or the antimuscarinic drugs causes suppression of thermoregulatory sweat glands. Again, so by suppression of this thermoregulatory sweat glands, it causes increase in temperature, and we call it atropine fever. Mainly children are more susceptible to this atropine fever because they release their heat by these thermoregulatory sweat glands more and more. So if at normal doses, even in normal doses, children can show atropine fever. Okay, here I am going to talk about a case called OPC poisoning. Okay, so in OPC poisoning, we use the drug atropine as antidote. Okay, so OPC poisoning, OPC, the organophosphate compound, is a cholinergic agonist drug. Okay, this compound, OPC organophosphate compound, bind with the cholinesterase irreversibly. So they bind with the cholinesterase irreversibly, and they prevent the breakdown of the acetylcholine. So acetylcholine cannot be breakdown. So there will be increase in acetylcholine and there will be toxicity. So we use the atropine here to reverse the muscarinic effect of the acetylcholine. Okay, we have to give, if a patient with OPC poisoning comes to you, you have to give 1 to 2 milligram IV of atropine every 5 to 15 minutes. Okay, until atropinization occurs. So if patient comes to you with OPC poisoning, you detect that this is OPC poisoning. Okay, so how will you detect that this is OPC poisoning? Okay, so you will see that there is increase in acetylcholine, so there will be increase in cholinergic stimulation. So what will happen? Increased sweating, increased salivation, increased lacrimation. There will be increase in urinary output. There will be increase in so he will urinate. Okay, and there will be diarrhea. Okay, and the most important thing that in the eyes you will see meiosis. Okay, so people will be small. You will see that the meiosis. Okay, so by these characteristics you will find out that this is the case of OPC poisoning. And here you will give atropine as an antidote, and you have to give it 1 to 2 milligram IV every 5 to 15 minutes until atropinization occurs. Okay, so what is atropinization? What is atropinization? When you can confirm that yes, I should stop giving atropine because atropinization has occurred. Okay, you will see that mydriasis has occurred and dry mouth and dry eyes. So if you see these characteristics, you will call it atropinization has occurred, and I should now I should stop giving atropine. There is also another drug called cholinesterase reversible. Cholinesterase reversible compound. Okay, and they are called oximes group of drug. Okay, we have pralidoxime, obidoxime drug. We have also diacetyl monoxime drug. So how they causes reverse the cholinesterase enzyme? When the OPC binds, or we can say that if it's a cholinesterase enzyme, see that is cholinesterase enzyme. Okay, cholinesterase enzyme. Okay, so it has two binding sites. It has an esteric binding site, asteric binding site, and it has an anionic binding site. Okay, so in asteric binding site, by the phosphate compound, OPC binds with this cholinesterase. And if we give pralidoxime, it binds with the anionic binding site. Pralidoxime binds with the anionic binding site. And what it causes, this pralidoxime, from here, it causes breakdown of this phosphate group. And it relieves the cholinesterase free from this OPC compound. They break the phosphate group and take away this OPC poison. Okay, and the cholinesterase is free, and they can break the acetylcholine. So we can give pralidoxime if a patient comes within 8 to 12 hours of poisoning. After 8 to 12 hours of poisoning, there will be aging of the OPC poisoning. We have already talked about aging in our in my other video. But what is aging? Aging is there is an alkyl group in organophosphate compound. If this alkyl group is released after binding to the cholinesterase, okay, if the alkyl group is released after binding to the cholinesterase, preludoxime can't reverse the cholinesterase enzyme or can't break the bond between the organophosphate compound and the cholinesterase. Okay, so this is called aging. So that's all for this video. Thank you very much.